So we're going to be talking a little bit about ophthalmologic injuries from the point of view of ringside medicine. And the common ocular injuries are going to be corneal abrasions, maybe lens dislocations, traumatic iritis, not so much, hyphema, retinal detachments, and hopefully we'll never see a ruptured globe. Corneal abrasions are pretty common. Usually what happens in a corneal abrasion, very frequently the refs know. Somebody may be measuring, distance, especially in an MMA event, more likely in an MMA event because the glove is closed in boxing. And somebody's measuring and accidentally, or deliberately sometimes, the hands and fingers kind of get into the eye. And so what happens is there is a laceration or an abrasion, and there's a reflex mechanism you can't see. Okay, your natural instinct is going to be to cover that eye, and you can't see. So what happens is, as you all know, there's timeout for 5 minutes, up to 5 minutes for an accidental foul, based on what the referee sees, and a doctor will be called in at that time, usually if the referee is told that the fighter can't see, right? So as a ringside physician, when you come in, the first thing we're going to do is check pupillary reflexes, ask somebody, can you see? And it's very interesting. Sometimes the fighter will tell you that their vision is blurred. Sometimes they'll say, no, I can't see anything, which may or may not be a way of their telling you gracefully that they've had enough. And that's the determination of the ringside physician at that time to say, hey, are we giving this person, whether it be an amateur or a pro, an out at that point, saying, I've had enough. And it's our responsibility, first and foremost, to protect that fighter. And I will take that hit. And in fact, I have taken that hit on multiple occasions. If anybody saw the Scott Smith-Robbie Lawler fight, I think that was the first time I had been, if you had a boo meter, would have been off the charts. Had to stop that fight because he just told me over and over again he couldn't see. And so there was nothing I could do. Now, whether or not I felt that that was the case at the time is another issue, but it was my job to protect that fighter. And despite the protestations afterwards, I still think it was the right call. Okay? There's a picture here of Bisping, and you can see, I'd like people tell me what you're seeing here, because this should never really get to this point. Okay? This is after his surgeries. Right? So you can see, you don't need to know much. The body is a marvelous thing. We're very symmetric usually, right? So you can see here, you don't need to know much, that right here, his facial symmetry is off, right? That eye looks sunken. And that's probably because there was some herniation and during the reconstruction after an orbital blowout fracture. And with the reconstruction, it probably wasn't complete. Okay, and this is just your basic anatomy of the eye. I don't really want to go into it too much, just to say that the lens is sitting here, right? The cornea is the right side. In the back, we see the retina, okay? And when that's disturbed, usually your fighters will tell you they're seeing flashing lights, or if there's a detachment, they may tell you that they're seeing a curtain-like effect, okay? And those things are very important. They may say that first to a ref, or more importantly, when somebody goes back to a corner. This is where the inspectors come in. It's really important, and where it's important for all of us to communicate. They may say to their coach, I'm seeing flashing lights, or I feel like there's a curtain or something going on. And that's the inspector's job to kind of communicate back either to the ref or to the doctors that something's happening. And clearly a retinal detachment would be an absolute indication to stop a fight.
This is a fight that was actually here in in Dallas. It's one of our mega fights. It was the Antonio Margarito fight. And basically what this was a couple of injuries that he sustained that we didn't really pick up until at the end of the fight. He sustained multiple blows to the face. He had a lot of soft tissue swelling. But when you just look at this picture here, it basically looks like a guy who's had a fair amount of punches to the face, eye is shut, looks okay, really not that bad. He's still fighting, he's still defending himself. He went through the entire fight. We didn't stop the fight. But if you remember, for anyone who watched the fight, there were a couple of times that we went in to check his vision. We checked his vision, he said he could see, Everything looked okay. We continued the fight. We got to the end, and we checked him in the back, and we felt a defect. It was soft down here. He really couldn't see. His eye was sunken down a little bit, and we realized that he had a fracture. So he had a fracture of his orbit, and he was sent immediately to the emergency room and had surgery. This goes into, as an aside, some of the things where you have to be firm in terms of your decisions. This is a major fight. Pacquiao had given his interview in the back. They wanted Margarito's interview. And we were like, no, he can't give his interview. He needs to go to the emergency room. And the trainers and everyone is saying, well, this guy needs to really give this interview. Everyone wants to hear what he has to say. And it's like, you have to stand firm. You can't bow to the pressures of what's going on, and your primary concern is for the combatant. And we said no. We put him in, and he gets sent. To kind of fast forward this and kind of capsulize it, he basically had surgery. From his injury, he developed a traumatic cataract, which is a clouding of his lens. And he wound up getting an approval to fight in another state. Had to fight in another state, had some difficulties. The initial pre-fight eval said that he was basically not safe to fight because of his eye. Because of some things that went on, that wasn't really the case, and the fight went on. The fight happened, he lost, and then there were, statements as to why wasn't the fight stopped earlier, why wasn't the fight stopped on the front end, and all of these things. So it goes to show that the higher up we go and we cover these high-end fights, there are a lot of things that go on. It's the same with lacerations. It's the same with stopping fights, that everyone has some degree of exposure. And you don't need to think of it in terms of the exposure. You just need to think of it in terms of doing what's right. So if you would stop it for USA boxing, and you need to stop it for a pro, it doesn't matter if they're fighting whomever within the next 6 months.
I was just going to add a clinical pearl. So, in this case, as Dr. Lee has already said, there's swelling there, and it's kind of difficult to assess whether or not there's an orbital fracture. You may or may not be able to see, for the doctors in the room, or feel a step off in the bone, in the zygomatic arch. And you may or may not see entrapment of the eye musculature. So very frequently what I do is if I have a patient like this and I'm concerned about a fracture, I'll ask them to lie on their back, because if there's a full orbital fracture, that portion of the face is going to sink down from gravity. And it's a really nice indication when there's a lot of swelling. So it's a nice post-fight check in clinical pearl.
Just another thing that I've noticed in my practice is a mistake that I see my residents make is they focus on the injured side, and they'll cover the non-injured eye and assess the vision in the injured side, and they say, well, I think he's okay. And in a case like this, you really have to check both eyes at the same time, because double vision is what's going to tell you if he has that entrapment. Yes. So throughout the course of a fight, checking and only covering the non-injured eye, checking the injured eye, can give you a little false sense of security that there's not a bad injury there.
That's very true. Again, this is some photographs showing examples of orbital fractures. You see here some entrapment of the eye, where you have a forward gaze here. This one is an upward gaze because the eye is sunken into the orbital floor here. This here indicates the fracture that you can't see on this side. Bone is intact, fracture's over here. And then when you look at the post-repair from here, you see that the gaze, although still a little off, it's better than what it was on the upper one.
This is what we would do for corneal abrasion in the back if we're concerned. Frequently the most frequent symptoms would be tearing, photophobia, or light sensitivity and pain. In the treatment, what we would do is do a fluorescein stain. So there are little strips that we carry around, and what you'll see is we'll bright light this, and the area, you can actually see the scratch pretty easily, is highlighted right there. And then you're going to patch and refer, and the treatment is antibiotics, and there's a 100% cure if medical regimen is followed. Yes?
One of the things we also teach is PRK and LASIX. With the corneal abrasion. And that's one of the difficulties I've had is I don't know if the fighter never tells me if they've had PRK and LASIX, because that does also change how you would treat the corneal abrasion as well.
In the ABC medical recommendations are that fighters do not fight with older LASIK. And the reason is because there's an actual cut into the globe of the eye. So it weakens the eye, and many experts in the field, Dr. Carreri being one of them, Dr. Zagelbaum, they're probably two of the foremost ophthalmologists in combat sports these days, and are the ABC Medical Committee's consultants. And they basically have said that eye, if it gets punched, is at risk. So LASIK, the older LASIK surgeries are contraindication. And that should be part of your pre-fight form to be asked. PRK is kind of a lasering, so it's a totally different mechanism and does not put the globe at risk, so that's a very good point. It's less to do with corneal abrasions than the actual mechanism of global rupture, potentially. There is a newer form of LASIK that is similar to PRK, but it's a much, much newer procedure. So what we recommend is that in the pre-fight evaluations prior to even getting licensing, that the ophthalmologists submit to the commission and your reviewing physicians the paperwork so that we know exactly what the procedure was, so that you're not surprised fight night and your ringside doctor is not surprised fight night and you're like, oh yeah, I had a surgical procedure on my eye. I don't remember if it was PRK or LASIK, and I can't remember the year. Then you're stuck. And from my point of view, I'm usually the bad guy. I err on the side of being conservative. And I'll say, look, if you don't know, I can't pass you. So if you can get your doctor to fax that information to me now, I'll review it for you as a favor fight night, especially if it's a big fight. But usually if that paperwork isn't in and I don't know, I can't pass that fighter.
Any other questions? Yes, in the back.
What would the term of limitations be on that LASIK surgery? Like, how far are we looking back as far as like what to ask? On the referee standpoint, let's say after a referee's rules meeting, it'd be a good time to ask those questions as well, just to double check on our end. But what would be the term of limitations on that?
You're asking like how far back?
How long ago was the procedure done? Because I'm not a doctor, so I wouldn't know what an old versus new LASIK
Well, you have to be careful because doctors do what they're trained to do, so some of them may not even do the newer procedures. So you kind of need to know what the procedure was. But before, I would say, what, 2005, 2005, 2007? Is that correct? Yeah, about that. 2005, 2007 is sort of the borderline where you start asking maybe there's a little bit of a different switchover.
I saw in that slide you had up there where you had a blowout fracture that was partially repaired. You could still have a little bit of wandering vision on that. In a situation like that where you haven't had full restoration of eye movement after surgery, is that a contraindication for further fights?
Well, typically with any of those, and that's a good question, typically what happens is when we render a fighter on suspension, it's pending an approval or review by that specialty. So what will happen is the fighter has his surgery, then we send him to have an evaluation by an ophthalmologist in this case, or an ENT person, and they have to give a clearance. Depending on who it is, and we see it, if we think it's still questionable, we may not even approve him. So that's why I said it depends. Just because we have someone with specialty and they send the stuff, if they're not sending it for what it is that we're looking for, we don't approve. I had, just as an aside, going on the area of specialization, there was a review that I had to do for the state, for the advisory board, where there was a fighter who had vision, who was blind in the eye by legal terms, in terms of what his vision score was. He had a report from an optometrist that said he could see. I denied him his ability to fight. It was appealed, and so basically when we go through the appeal process, it's reviewed by a judge. So we're doing a telephone conference, and the judge is going through everything, and basically the judge said, well, did you physically see the patient to see whether or not he can see? And I said, no, I don't have to. The numbers speak for themselves. If you have this vision, you know, outline, you can't see. Well, because you didn't see the guy, why would you deny him his right? I'm going to overrule. And so, because that was a legal issue, but when I turned in the report, I said that's still, the guy is still visually impaired, and because of the communication, he still had his license denied. So it's one of those things that just because we get the review, we still have to use our common sense and kind of see. If you have this guy coming back and the guy says he's okay, and in the back of your mind you're saying you don't think it's okay, you put in your opinion, and then that goes through the committee, and ultimately the executive committee, the executive director, Greg, and those guys would come up with a joint decision in terms of what's best for the fighter. It's a long-winded explanation, but that's pretty much what goes on. IFEMA is a medical emergency, and basically it's blood in the anterior chamber of the eye. This, if you see this during the course of a fight, it's a stoppage. It's a stoppage because of risk of loss of vision. We patch them and they get sent out. Now, can the guy answer questions? Yes. Can the guy respond? Yes. Can he walk? Yes. But it's knowing that this is a potential problem that you have to be able to stop the fight. And again, these are one of these little areas that it's not many of these things that you see, but you still need to know that if you see this, that this is a stoppage. This is an absolute indication to stop a fight, to let the ref know that the fight needs to be stopped because of imminent loss of vision.